Afternoon. Welcome to UCSF Family Community Medicine Grand Rounds. We are really excited to see you here today. My name is Margot Venner, and it is my pleasure to introduce you to our phenomenal Grand Rounds program for today. But first, a couple quick announcements. The first one is just to remind you that this session is being recorded. If you're interested in seeing other Grand Round sessions that you've missed for UCSF Family Medicine Grand Rounds, you can look on our website where you can see previous sessions. Also, if you're interested in submitting an evaluation with comments for our speakers or for any of us on today's Grand Rounds, there'll be a link in the chat that you can respond to. In addition, we're hoping that this will be an interactive session today. We've got some really dynamic presenters and they would love to hear your questions. So please use the Q&A section to ask questions for our presenters, and we will try to answer them either written or live. And as always, if you have any thoughts or feedback about these sessions, please feel free to reach out to me, margot.venner@ucsf.edu. I am really excited to see all of you remotely, and even particularly excited about our topic for today, which is screening for adverse social determinants of health or social risk factors. This has become an increasingly common concern in healthcare settings. There's growing evidence to support activities to identify and intervene on patient social risk factors with the goal of improving patient health, wellness, and wellness equity. Researchers from UCSF today will discuss the acceptability of social risk screening from the perspective of patients and caregivers of pediatric patients and adult patients, and current screening activities at UCSF and ZSFG. Our presenters today are Dr. Emilia De Marchis. Emilia is a family physician and health services researcher at the University of California, San Francisco. Her research is based out of the UCSF Social Intervention Research and Evaluation Network, otherwise known as SIREN, where she works to assess and improve how we screen for and address social risk factors within healthcare settings. Her work is based out of the UCSF Family Medicine Center at Lakeshore, where she provides primary care. Dr. Matt Pentel is a UCSF professor and works with the SIREN program as well as the UCSF Preterm Birth Initiative. His research focuses on the utility of incorporating social information into clinical decision-making, addressing social needs in clinical settings, data mining, and the analysis of large data sets, as well as the biological manifestations of social determinants of health. Clinically, Dr. Pentel works as a pediatric hospitalist at UCSF Benny Hoff's Children's Hospital at Mission Bay, as well as Washington Hospital in Fremont. He works as a pediatric care physician in addition, and runs the tattoo removal clinic at ZSFG. And Dr. Caroline Fichtenberg is the managing director of SIREN, the Social Interventions Research and Evaluation Network. And she's also a research scientist in the Department of Family and Community Medicine. And in these roles, she leads efforts to conduct, catalyze, and disseminate high-quality research on health sector strategies to reduce health inequities by addressing social determinants of health. She brings these positions more than a decade of experience working to improve health and economic outcomes for America's most vulnerable families, including 7 years in working on national efforts in Washington, D.C. So it is my great pleasure to welcome our group of speakers today, and we look forward to hearing your questions. Thank you.
Thank you so much, Margot. Hi, everybody. I am going to be giving you a quick overview of SIREN for those of you who are not familiar with SIREN. And I want to just check. I don't see the slides, but our, okay, there we go. Folks can see the slides now, or they're coming up. Thanks, Matt. So I want to give you just a brief introduction about SIREN for those of you who are not familiar with us. Next slide. So as you've just heard, SIREN is the Social Interventions Research and Evaluation Network, and we're a research center housed at UCSF that focuses specifically on improving research on social and medical care integration. For those of you who may not be as familiar with this as we are, social and medical care integration encompasses all of the ways in which healthcare teams and organizations can improve health outcomes and health equity by better understanding the social risks and social conditions that shape patients' health, what we often call the social determinants of health, and using that information both to improve clinical care and to help patients and communities address those risks and conditions. And I want to say at the outset that we're motivated in this work by the belief that we will not substantially address health inequities, particularly inequities related to racism and inequities in socioeconomic status, if we do not better integrate considerations of social determinants of health into healthcare. And so today you're going to be hearing some very concrete things that can be done about this. Next slide. Really quickly, here are the folks at UCSF that are most directly involved in SIREN. And two of them you're going to be hearing from directly today, Emilia De Marchis and Matt Pentel, who are on the lower hand of the screen. We also collaborate with a lot of other folks at UCSF and in other departments. And we also are connected to a group of some 30 researchers and practitioners around the country that help advise our activities. And just for those of you who are wondering, like, how do these centers come about? How do these efforts work? Our work is funded through a combination of private foundation grants as well as federal grants. Next slide. I want to highlight a few of the things that we do on our dissemination, on the dissemination side of our work before going further. One of our main dissemination activities is our evidence and resource library. This is a searchable database of evidence, resource tools on healthcare-based social interventions. You can find it at the URL that you see at the top of the screen. And the idea behind this is that it's actually pretty hard to find a lot of this research because there's not one single term that you can use to describe it or that's widely used to describe it, or no one specific term. And so we wanted to make it easy and create a one-stop shop for people who want to find both academic and non-academic research resources on this. And that's what this website is. We updated it on a monthly basis. And so it's a great place to go and find both academic research as well as tools, toolkits. We have screening tools, et cetera there. Lots of resources. Next slide. We also put out a newsletter every month that summarizes all the latest research and resources that has come out in the previous months. So if you want to stay on top of the literature in real time, this is a great way to do it. And you can sign up for this on our website. Next slide. We also do events to help highlight issues as well as research in this space. This year, we've been running a series of webinars that have also been made into podcasts. It's called Coffee and Science. And so you can listen to it on any of your favorite podcast apps. Highly recommend it. And then finally, we have in the past, next slide, we organized a couple of years ago the first national meeting for researchers working specifically on these social determinants interventions in healthcare settings. We hope one day to be able to convene people in person again at some point in the future. Next slide. So before turning it over to Dr. De Marchis, I want to just give you a little bit of a framework for how we think of a lot of the work in this space. And this framework comes from this report, Integrating Social Care into the Delivery of Healthcare, that was published in 2019 by the National Academies of Science, Engineering, and Medicine. And this report sought to answer the question, given that social factors play such an important role in shaping health and health inequities, what should the healthcare sector do about these social factors? Next slide. So this report answered this question in the form of this framework, the 5 A's framework for integration of social care into healthcare. And this framework lays out 5 sets of strategies that can be used by the healthcare sector in light of the fact that social factors have such an influence on health and health inequities. The first 3 strategies on blue in this slide are patient-focused strategies, and the second are community societally focused, the 2 in green. And I'm going to briefly review these for you. So the first strategy is awareness, which is exactly what it sounds like. This is various strategies that healthcare systems and teams can use to become aware of patients' social risks and conditions. And that's going to be the focus of today's presentation. But I want to highlight the other four briefly to give you a sense of the complete framework. Next is adjustment. And this is the idea that to ensure high quality care when patients have substantial social risks that are barriers to health, that it is important to think about whether or not there are any modifications or adjustment to care that are needed to ensure that patients can have good health despite these social risks. These are things like prescribing less expensive medications for patients whose health insurance might not fully cover medication costs, or bundling appointments and time for patients facing transportation challenges. It's the kinds of things that I think many providers serving low economically resourced patients have often done, but there hasn't always been a name for it. And so adjustments tries to shine a spotlight on this and provide more resources to help care teams do this. And next November, the next Grand Rounds will focus on this topic. Third is the idea of assistance, and this is the way in which healthcare teams can provide resources and services to address social risks. So this can take the form of directly providing resources, for example, through a food pantry or food vouchers or co-located legal services, or connecting patients to external resources such as eviction prevention, et cetera. And then the last two strategies, which I'll describe together because they go hand in hand, are ways in which healthcare organizations can work at the community level, at state and national levels, to bring all of the resources to bear to address the social conditions that create the social risks that affect health. And we're seeing a lot of work in this area, and hopefully at some point in a future Grand Round or in other settings, we can share more about the work happening in this area. For right now, though, I want to turn it over to Dr. De Marchis and then Dr. Pantel to talk about awareness strategies. Emilia, on to you.
Thank you so much. And thanks, Matt. It's great to be here today. Thanks for having me. So as noted, I'm an assistant professor in the Department of Family and Community Medicine and a practicing family physician and researcher implementation scientist based out of SIREN. And I was drawn to UCSF for residency, given my interest in research in academic medicine and underserved medicine. And after residency, went on to complete a master's in clinical research and certificate in implementation science at UCSF as part of the primary care research fellowship. I began working with SIREN during residency, as much as one can do research in residency, and have been fortunate to continue on since then. And today I'll be discussing a 2019 study that we did at SIREN to evaluate the acceptability of social risk screening to patients and caregivers of pediatric patients, an important aspect of that awareness of social risks that Caroline mentioned. Next slide. I just want to acknowledge the Commonwealth Fund as the primary funder for this study, as well as SIREN and the Primary Care Research Fellowship I completed during this study period. Next slide. Amidst mounting evidence of the impact of social risk factors to health, there's been a policy push to integrate social risk screening into healthcare. And this is supported by the American Academy of Family Physicians, among others. Next slide. And while there's been some research on the acceptability of social risk screening, much has focused on provider or staff perspectives, and patient attitudes towards social risk screening has predominantly focused on a single domain, such as food insecurity screening, and been limited to a single clinical site and predominantly taken place in a pediatric patient population. Next slide. So with all the excitement around social risk screening, we at SIREN wanted to explore patient acceptability in diverse healthcare settings. Next slide. In 2017, the Center for Medicare Medicaid Innovation published a 10-item screening tool as part of its Accountable Health Communities demonstration project. And this program requires screening for 5 socioeconomic actionable domains, which include housing, both stability and quality, transportation, both medical and non-medical, utility security, food security, and personal safety. And while some of the individual screening questions came from independently validated screening tools, such as the hunger vital signs for food insecurity, there was not any formal research done on the comprehensive tool other than some unpublished cognitive testing that they conducted with about 30 patients. So we saw this as an opportunity to study patient acceptability of social risk screening using a multi-domain tool endorsed by a federal agency. Next slide. Our goal was to understand the acceptability of social risk screening to patients and caregivers of pediatric patients. And next slide. We launched a mixed method study at 10 different clinical sites across the US, including 4 family medicine, 2 internal medicine, 2 general emergency departments, and 2 pediatric emergency departments. And 2 of our sites we were fortunate to have locally. The blue circles are the actual Center for Medicare and Medicaid Innovation Accountable Health Community sites. And the stars indicate where our study sites were located, none of which were actually taking part by design in the AHC demonstration. And next slide. So we used fixed convergent methods as a mixed method study, which means that it was a cross-sectional one point in time in which we did quantitative surveys at the same time as the qualitative interview data was collected. And we did both the survey and interviews at the same time with the intention of merging the findings. Each site recruited 100 English or Spanish-speaking patients or pediatric caregivers to complete a survey that included the CMMI 10-item screening tool, in addition to questions about their perspectives on screening. And additionally, each site was asked to conduct 5 interviews with a random subset of survey participants. So I'm going to briefly go over these results and conclusions. So next slide. We used 2 measures of acceptability in our surveys. For one, the respondents' perspectives on the appropriateness of screening in healthcare settings, and 2, their comfort with that social risk screening information then being included in their electronic health records. And next slide. So we hypothesized that multiple different factors would contribute to acceptability, including having been exposed to screening in a healthcare setting in the past, being surveyed in a safety net setting, participants' trust in their providers, and we thought that something like an experience of discrimination within a healthcare setting would probably decrease acceptability of screening. Next slide. So this table is just showing the responses to the survey question in terms of how much people were screening positive for the different social risk factors on the screening tool. And you see that we had across the 10 sites, 50 interview participants and 955 participants who completed the survey only. And we had about 40% who were screened positive for housing-related social risks, similar number for food insecurity, more in the 20-teen percentage for the transportation utilities, and much fewer who screened positive for safety concerns. And we see that close to about 50% almost had one or more, 1 to 2 risk factors, and about 15% had 3 to 5 of these risks. Next slide. In terms of the acceptability, what did we find? This graph shows participants' responses to the question asking, how appropriate is it to be screened for social risks at this healthcare setting? And responses from patients and caregivers recruited from the emergency departments are on the top bar. The second bar are the responses from primary care, and the bottom is all the respondents together. And so we found that overall about 80% of the participants in both settings thought screening was appropriate. And recall that this question was asked about the appropriateness of being screened in the setting that they were being surveyed at that moment. Next slide. And for our second question, comfort with social risk data being included in the electronic health record, we again see that the majority of participants noted being comfortable with EHR integration with similar findings across study sites. Next slide. So just to recap, a strong majority of participants thought screening was appropriate. 83% in primary care and 75% in emergency departments thought that screening was very or somewhat appropriate. And only about 7% thought that screening was inappropriate. And 66% in primary care and 62% of emergency department respondents were comfortable with screening information being included in the electronic health record, with about 20% being uncomfortable with EHR integration of screening results. Next slide. We also explored what factors were associated with acceptability. And so we ran multivariable models so that we could look at what different factors were contributing to whether or not someone seemed to think that screening was appropriate or not, or comfortable with the EHR integration or not. And this is showing adjusted odds ratios. So that what would be associated with higher odds of appropriateness or increased odds of comfort. And the stars are just to indicate that what results were statistically significant. And so respondents who had previously experienced social risk screening in a healthcare setting, those who'd been seen in a healthcare setting with higher number of publicly insured or uninsured patients who had higher trust in their clinicians, had higher odds of reporting that screening was appropriate. And they had lower odds of reporting that screening was appropriate if they had experienced discrimination in the past. And only prior assistance with social risks in a healthcare setting was significantly associated with a higher odds of feeling comfortable with screening results being integrated in the EHR. Next slide. So in summary, with the survey data, including patients from 10 different clinical sites around the US, respondents reported high levels of acceptability of social risk screening, and more respondents thought screening was appropriate than were comfortable with their social risk data being in their EHR. And next slide. And factors like prior exposure to screening and trust significantly or slightly increased the appropriateness of screening, but experiences of prior discrimination slightly decreased the appropriateness of screening, whereas prior assistance with social risk from a healthcare setting slightly increased comfort with including social risk data in the EHR. So now I'm going to switch over to the interview results. Next slide. So through interviews, we wanted to explore patients' emotional response to survey questions, their experience and the context that contributed to their survey responses, and to get more details on their perspectives. Next slide. And we had 4 main themes that emerged from our interviews. 1, participants thought screening was important to do. They had strong insight into the connection between their health and social risks. They called for a patient-centered implementation of screening, and they recognized the limitations of the healthcare system to resolve their social risk factors. Next slide. So moving into some representative quotes from participants in our 4 themes. For the first theme of screening being important to do, participants expressed a sense of gratitude and at times relief that they were being screened for social risks, and at times noted how screening could improve the healthcare team patient relationship. It was a great survey to take. Actually, I'm glad I took it to see that somebody out there actually cares, you know. And they also noted how screening was important to the healthcare team to fully know a patient. I think it's important for it to be in the chart because our medical providers, they can, you know, take into account consideration and look at the entire person, not just the symptoms that are coming in. Next slide. And for the theme of participants recognizing the connection between health and social risks, participants would note how stress from social needs impacts health. So stress impacts health like crazy. Poverty and living at a survival level, whether it's your safety or finances or whatever, is massively stressful. I'm sure it just makes everything 10 times worse. Next slide. Next slide. They also mentioned how knowing social risks could help physicians understand a patient's conditions, so that my doctor knows why I have headaches due to stress because I have no place to live. And next slide. And for a desire for a patient-centered implementation, respondents noted the importance of a compassionate and empathic approach to screening so that they would know that screening was occurring out of care and a desire to understand, not just to collect information. I don't mind because if I feel like somebody is concerned, really concerned about me, I will answer the question. But if I feel like there's somebody just asking me the question just to be asking me because that's part of their job, I might not answer. Next slide. And next slide. And privacy concerns and fear of being judged by those outside their healthcare team were also noted in how this tied into comfort responding to screening questions. So the doctor can tell other people what's going on, but people talk and you don't want your business spread around. Next slide. And another noted, like with my first doctor, I wouldn't have shared. Next slide. Finally, under the theme of participants recognizing the limitations of the healthcare system, participants said things related to how they didn't think healthcare should or could resolve social risks, and they didn't expect resolution from screening. So when asked about whether the healthcare system should address patient social risks, one participant noted, "I don't know in the way medicine is practiced right now, it could, whether it would, send doctors over the top. I mean, I just don't see there's time for it." And next slide. Another participant noted, "But as far as the healthcare providers, I don't really see it as their responsibility. I think they should ask the questions. I'm not sure that they should be responsible for helping them." Next slide. So bringing all the data together, how did our qualitative, the interview findings compare to or support or not support the survey results? Next slide. We thought that overall our results were very complementary. As an example, interviews provided a more nuanced understanding of the subset of survey respondents who thought that screening was appropriate, but were uncomfortable with that social risk data being integrated into the EHR. Next slide. In their interviews, a recurrent theme was that they were not comfortable with how their data would be used outside of the healthcare team. And next slide. So taken together, our findings suggest that screening is acceptable. Patients and caregivers see it as important to do. They note that social risks are related to health. And when done in a patient-centered and empathic way, many noted that it can strengthen the patient healthcare team relationship. And patients also saw the limits to what the healthcare system could or should do, but were pro-screening regardless. Next slide. So what does this mean for actually implementing social risk screening in a healthcare setting? Based on what we heard in interviews, there are implications for staff training and workflow in terms of ensuring a patient-centered approach, and the need to further evaluate how social risk screening results are documented, given concerns about privacy and sharing information beyond patients' immediate healthcare team. Next slide. I just want to acknowledge some limitations of this work from this multi-site study. It is just one study. It was, I will say there have been a study published since then that supports many of these findings. And it was a cross-sectional survey, so just one point in time. We excluded patients who did not speak or read English or Spanish. And although we included a diverse set of study sites, our sites are not representative of all healthcare settings. There's some active research going on in this area now in specialty clinics. And our research questions were asked theoretically, so as part of a research study. And finally, there may be other factors that influence acceptability that our study wasn't designed to test for. And next slide. For those interested, these are two publications that came out on acceptability from this study. And with that, I want to thank all of our study sites and the patients and caregivers for their participation in the study. And I will pass it over to Matt.
All right, thanks, Emilia, and thanks everybody for the opportunity to talk about our work. And yeah, I just wanted to let everybody know about how I came into this work. I was trained at the UC Berkeley UCSF Joint Medical Program for med school, which combines public health training at Berkeley with clinical work at UCSF. And so got exposed to a lot of social epidemiology and social determinants of health work there, and was fortunate enough to start working with Dr. Laura Gottlieb and SIREN during residency when I did my pediatrics residency here. And so got more interested in this type of research and applying and implementing this type of work in clinical settings, and happy to talk to any of the learners about other opportunities. So I'm going to talk with you a little bit about what's going on in terms of screening for social determinants of health and social needs around the country, but also in some of our communities more locally. And so in a study conducted by Dr. Teresa Freyes, who's an affiliate faculty in SIREN, she analyzed the National Survey of Healthcare Organizations and Systems, which included 2,300 physician practices and about 750 hospitals. And I had a question asking, does your practice have a system in place to screen patients for food insecurity, housing instability, utility needs, transportation needs, or interpersonal violence, IPV? What she found over here is that, in terms of practices, the most commonly cited infrastructure for screening for social needs was for IPV at about almost 60%, and that the other four social needs were sort of between 20 and 40%. Then looking at hospitals, actually IPV and transportation needs were in the high 70s in terms of having a system in place to screen for them. housing stability at about 60%, and then food and security and utility needs a little bit lower, less than 50%, each of them. And then, when asked about, do you screen for 0, 1, 2, 3, 4, or 5, the good news was that, a minority of them said that they screen for 0. Although, as you could see here among practices, only about 17, 18% screen for all 5 and have a system in place versus, about 23% in hospital systems. So it's more likely they're screening for, between 1 to 4, not necessarily all 5. So this is essentially talking about, asking people to answer for their whole health system, but there's actually a lot of variation when you look at the individual level. And it's hard to sort of see this in national studies because it's hard to figure out where this is documented and extracting the data. One way to try to look at this is to look at social determinants of health ICD codes. So these are the medical codes we usually put in our notes, clinicians do for diagnoses, pneumonia, influenza, that type of thing, but they actually also have social determinants of health ICD codes as well. So in a study conducted by Dr. Jackie Torres and colleagues looking at a national inpatient sample of 4,300 hospitals in 44 states, representing about 35.5 million discharges, they looked at how frequently ICD codes for social determinants of health were actually used. And if you want to look at what some of these ICD codes for social determinants of health are, you can go to a compendium on the SIREN website. What she found was that actually ICD social code use is very limited. So this is per 10,000 discharges. What she found is that any social ICD code was only used in 163 out of 10,000 discharges. So very low rates of documentation, despite the estimated prevalence of these. The most commonly documented ICD code was a problem related to housing or economic circumstances. But again, that's only in 70 per 10,000 discharges. And one of the things we confirmed here is we looked at among pediatric social ICD codes as well. And we found that using a nationwide readmission database, only 0.58% of discharges had an ICD social code. We also looked at the California Office of Statewide Health Planning and Development, and 2.8 million women and birthing people giving birth over 2007 to 2012. What we found is among these 2.8 million women and birthing people, only 2,800 had an ICD code for unstable housing, despite the unfortunate estimated prevalence of about 1 to 4% of women and birthing people experiencing unstable housing around the time they give birth. One of the limitations beyond the fact that these ICD social codes are used so infrequently is that you can only really document if there is the social risk factor present. You can't document if it's absent. There's no has stable housing code or lacks food and security code. So one way electronic health records are trying to get around this is actually developing specific social determinants of health screening modules, whereby they allow you to help document not only whether a social risk factor is present, but also whether it's absent. And the San Francisco Department of Public Health, when they implemented EPIC, the EHR system that they use now for all of the DPH clinics, they actually had a committee figure out which of 5 social determinants of health they really wanted to have and highlight in the EHR. And so what they chose here, and I'll show you in a second more closely, is they chose housing, food, transportation, utilities, and employment. And they help to create these little icons in the EHR that you could hover over, and that would lead you to screening questions. So if you hover over one of these things, here's utilities. It says in the past 12 months, has the electric, gas, oil, or water company threatened to shut off your services in your home? You can click yes, no, already shut off. So that way you can tell, looking at these icons after, red means that they possess the social risk factor. Gray means that they haven't been asked it yet. Green, which isn't an example here, but green means that they lack the risk factor. And then yellow is this sort of in-between risk, which is actually more for behavioral determinants like smoking. So since EPIC was implemented in August 2019, we looked at a data pool of about 1.5 years, so going through January 2021. And despite the many thousands of patients that DPH sees, tens of thousands, or I forget how many 100,000, but it's only had a documentation of housing in 7,700 patients, food and security in 2,400 patients, transportation in 600, employment in about 500, and utilities in about 250. So despite the tool being available, it's not necessarily always used. And so it can be hard to get these estimates of how often people are screening, even when these EHR tools are available. In terms of who is using it though, there's a wide variety of users and roles, the majority being registered nurses, and followed closely second at 27% with physicians and nurse practitioners. 14% were other roles, which include a bunch of different clinical and non-clinical staff. And then 13% were residents and medical assistants each. 2% were medical students. And this sort of emphasizes that there's a lot of champions using this module in particular, but that it's not everybody is using it equally. So on this x-axis right here is the number of clinicians using this tool, and it actually goes up to 1,055. It just gets cut off here. And this is the percentage of documentation that's occurred. And what we actually found is that you can see here between 93 and 116. So this is about 100 clinicians right here. And if you follow this up, 100 clinicians account for about 75% of all documentation efforts. So this is about 10% of the users are kind of these super documenters and screeners, whereas most of the other people are screening far fewer patients collectively. So then people talk about, what about looking in the note text itself and talking to clinical staff? A lot of them say, you know, I write stuff there because it's faster and more quick than clicking on a bunch of boxes. And a fairly newer tool to health research has been something called natural language processing, or NLP. And what this does is it actually searches free text, which is kind of like Command F or Control F on your computer. You sort of like looking for the term food insecurity or housing instability, although it's a lot more complicated than that. But essentially what it can do is it can be built to not only see these terms, but understand sentence structure to help identify whether or not social risk factors are present. And so Navaith and colleagues looked at a hospital system in Massachusetts at 49,000 patients hospitalized with cardiovascular disease, and looked for social and behavioral risk factors using both ICD codes and natural language processing to see, hey, maybe they're actually documenting this more in the notes. And here, this is the percent of prevalence, so the percent of patients with the documentation, with the social or behavioral factor documented. And what you can see here, looking at in black, this is what was identified via ICD codes. And in gray, this is what's identified using additionally NLP to search free word text. And what you can see is if you look with the free word text, you double your sensitivity of detecting housing instability. And for poor social support, no ICD social codes for that. But then when you look at the actual text, 16% of patients had poor social support documented. So this is really showing us that, you know, note text really has a lot of this information. It's just hard to extract it to estimate, you know, what the awareness and prevalence is. So why don't we use this all the time? The answer is that right now, NLP is really, it takes a lot of resources to come up with these models that go and search through words, and to apply it clinically, we're sort of way off from doing that. Dr. De Marchis is actually helping to lead a project looking at this and can talk about you know, how much effort you have to do to program and identify these terms such that it is actually sensitive and specific for the social risk factors that you're looking for. In addition, even though we're focusing mostly on awareness, I also wanted to talk about, you know, estimates of assistance and what people actually do when they identify social needs. Dr. De Marchis and colleagues conducted a study using the Health Center Patient Survey, which includes health centers funded by the Bureau of Primary Health Care, like community health centers and migrant health centers, and a random convenience sample of about 4,200 patients from 167 health centers. And what she and her colleagues found was that, you know, patients going to these clinics, you know, endorsed a wide range of social needs, but that the assistance didn't necessarily match up. So for example, 70% of patients said in the survey that they had employment issues, but only about 4% said that they got assistance with that. You know, about 32% said that they had housing issues, but only 3% said they got assistance with that from the clinic. And while the majority of patients were living under the 100% of the federal poverty level, only about a quarter of them received assistance with applying to government benefits. Now, this could be, we don't know how many were actually screened here. So it could be that only 4% were screened for employment or 3% were screened for housing. But the point is, you know, screening, the pathway from actually patients having things to screening to getting assistance does lead to sort of a drop off in what is actually done. And it is hard to get these estimates from sort of national data sets. You know, barriers to doing screening and providing assistance that we've identified from the literature and our own work, you know, some of the consistent ones have been just lack of time with so many things going on, lack of a clear workflow, unsure of what to do with the information once it's identified, and a lack of training in how to approach the screening. That being said, there's a lot of people on campus conducting this type of work, and I wanted to highlight a few of my colleagues. So Dr. Amy Whittle and Mr. Philip Herrera help run the Health Advocates Program, which was helped start by Dr. Gottlieb. This is a program that screens patients and families for social needs and then provides resources. And clinicians can refer patients to the advocates via email. So you can email Amy Whittle if you're interested in doing work related to this. This right here is showing the prevalence of social needs in blue, pre-pandemic, red, the first year of the pandemic, and green, the second year of the pandemic. What you can see is the health advocates identified big increases in food insecurity and some moderate increases in utility and housing when they were doing surveys during this time. Dr. Jane G has been doing primary care at Mount Zion and doing some work looking at social needs there, found that 55% of respondents had at least one health-related social need, with the most prevalent being housing instability, followed by financial strain and food insecurity. She said that the positive patient reception to screening with no concerns expressed. And right now they're doing a taxi voucher project where 11% of patients report transportation issues and 13% have a no-show rate. So they're investigating if those are related, and you can email her if you'd like to get involved with that. Dr. Stephanie Ranke, along with medical students, part of a clinical microsystems clerkship project where they do quality improvement work over the year, had a project last year to increase food insecurity screening for hospitalized patients from 2.9 to 10%. It's actually this year, from May to June 2021. And after employing a variety of interventions, they found that on the ward, they were able to increase it to 25% of patients being screened with a 15% positivity rate, compared to a similar ward, which only had about 2% of patients being screened. And finally, Dr. Sujatha Sankaran is doing a lot of different work in the Division of Hospital Medicine adult side at UCSF Health, with analyzing rates of screening for social determinants of health like housing and other social determinants here, as well as behavioral determinants like alcohol and substance abuse screening. So she's been analyzing that and helping to promote those efforts throughout UCSF Health. And also the UC Office of the President, or UCOP, has a committee that's exploring domains to potentially endorse for screening for all UC campuses, which will likely come out later this year. Finally, for the last 2 minutes, just wanted to go over a case study and what we've been doing at our pediatric inpatient ward. Along with my colleague, Dr. Nora Pfaff, she and I co-lead the Patient Social Needs Task Force. And the impetus was really seeing an increase in social needs during the COVID-19 pandemic and having this new EHR tool where we could document these needs. So we have a committee of nurses, social workers, residents, fellows, and attendings, and students attend as well when free. And the goal is to set standardized social needs screening priorities. We also were fortunate to have a group of medical students in their first year do this for their clinical microsystems clerkship, as well as the resident and fellows to elect this as their QI project, or what's called the Reflect project. Don't try to read this, just wanted to show you that we employed A3 thinking, which is sort of how to set up a problem statement and set up PDSA cycles at potential interventions to try to increase screening rates. We had a pre-pilot survey to 56 nurses and physicians and residents and attendings and fellows. And what you see here is, 4 and 5, purple and light blue, are the strongly agree. And people said that they thought that social information could be used to improve patient care, to improve communication with patients, to improve trust with them, and that they supported efforts to incorporate social determinants of health into healthcare, and it should be a standard part of the care that we provide. This was a barriers survey that we did with, again, 4 and 5. This is saying a major barrier on the right. So the ones identified as major barriers were insufficient time, inadequate screening tools available, unsure of whose role it was, lack of training in how to respond, and lack of resources to address social determinants. So we came up with some resources to try to combat those barriers. The task force rated social needs they thought were most relevant to our patient population, and we decided to screen for financial strain and food insecurity. And now all nurses screen patients for financial strain on admission, with physicians screening for food insecurity among those patients that are identified as having financial strain. And this is sort of the workflow we developed here. We have a food resources by county webpage that anybody can access here, and we print out for patients. Here's an example of the Alameda sheet with statewide and local resources. And then we also have some EHR tricks to sort of see how many people have been screened, with sort of columns showing how many people have been screened and are they positive, or green means that they're negative for the social needs. This is sort of our start of the pilot here, and this is the week of the pilot going on here. Our goal as a unit was to screen at least 40% of people for financial strain or food insecurity, and we started to hit that more consistently right here, week 20, and that's the purple line there. Orange is the food insecurity screening, which we're lagging behind a bit, and blue is hard to see is the financial strain screening. But the real key here was when we integrated financial strain into the workflow of nurses on the admission questionnaire, and then we saw that consistently going up. Now we're working to get the food insecurity go to a little bit higher. So some take-home points from this are that, hospitals and practices report moderate amounts of social determinants of health screening in aggregate, but there's wide variation by individual, unit, and system level. The social determinants of health documentation varies widely, with low rates with ICD codes and modules. It's more common to see this documented in text, which can be faster to write, but it's really hard to extract that data. And while many barriers exist to screening, many clinicians see value in social determinants of health screening. And there are a lot of efforts locally going on that you can get involved in related to screening for and providing assistance to social needs. For those interested, again, here is the link to the podcast, SIREN, Coffee and Science, which talks about hot topics in social and healthcare integration. And you can email any of us today if you have any more questions or want to see where you can get involved. Thank you so much.
Thanks, Matt.
Great. Maybe I can do the moderation of the question. There was a question from Stephen Lane for you, Emilia, asking you, why did you hypothesize that social determinants of health screening in a safety net setting would be more acceptable than screening in other care settings?
Yeah, great question. Thanks for the question, Stephen. We thought that in safety net settings, likely there would be a higher number of patients who would be experiencing adverse social determinants of health or social risks, and likely that those settings would already be very attuned to, and likely, if not formally screening, kind of be more likely having these conversations with their patients about adverse social determinants of health. So kind of that attributing to potentially they're being more comfortable with the screening happening. Even though we did also ask a separate question of if it was actually in the past 12 months, had you been screened for social risks within healthcare, not specifically just at their one clinic site. But, yeah.
Great, thank you. And then there's a question from Deb Bourne. What are models of response when someone screens positive?
Yeah.
I don't know if you want to, either one of you want to take that one?
Either I can go first, and then Matt, feel free to chime in. Many different models. I would say most all programs have an element of assistance, and that can take many different forms, either having kind of like resource lists that they're providing to patients for patients to follow up with on their own in terms of community-based resources, versus active navigation programs where there's actually follow-up and meeting with like a community health worker or social worker to help actually navigate and ensure that patients are making it to resources and they're eligible for resources. And kind of all along the spectrum in terms of the actual assistance. And then there's also that adjustment element that at SIREN we're very interested in, and kind of how clinicians are using that information to also ensure that their care is appropriate and accessible to patients at where they're at in their context.
Yeah, completely agree with Emilia. And it's sort of, as we've been shaping it at the Mission Bay Ward, the assistance, I think, is what we think of first. It's sort of here are resources or follow-up, but also we've been trying to use that adjustment. If someone has a transportation need, let's try to get all of their appointments on the same day with the 4 subspecialists, and that type of thing. So I think a lot of models think about assistance, and we're trying to also incorporate that adjustment to what can we do to adjust that care to make sure they're more likely to access it based on the social barriers they may have.
Great, thank you. Have social risk screenings, Matthew Goldman asked, have social risk screenings been studied in behavioral health settings as far as you know?
I am probably less familiar with the literature in behavioral health settings, but I know that behavioral health teams are often used to help with providing assistance. So in that way, yes, but still usually, like, I just know of like in the primary care settings, like with partnership with behavioral health. So there's usually close linkages in that regard.
Yeah, that would be a good, oh, sorry, Matt, you're going to add something?
No, I agree. I was just to say, agree with Emilia. And, a lot of actually the behavioral health assistants in DPH have actually been utilized to do some of the screening and provide resources, but I'm unaware of, looking specifically at behavioral health settings where it's been done, which doesn't mean it doesn't exist.
Yeah, it'd be a good thing for us to look in the evidence and resource library for. Great. And then Sam Dennison asks, was there any indication that class or race impacted feelings about acceptability? I think that's a question for you.
Yeah. So when we were looking at like multiple different factors together, so when we looked at race, ethnicity, in addition to discrimination, in addition to being in a safety net setting, discrimination was associated with less, lower odds of thinking that screening was appropriate in your healthcare setting, but the race, ethnicity itself was not. But likely it was that discrimination that was kind of the most important factor. And we know, unfortunately, that discrimination is often occurring due to someone's racism.
Stephen Lane wants to point out and highlight, and I really appreciate you highlighting this, that a number of social determinants of health data elements were recently added to version 2 of the US Core Data for Interoperability, US CDI. And I think everybody can see the chat, and there's a link there about this. And so this is hopefully going to help make it easier to be capturing data about social determinants of health in EHRs. So if you're interested in learning more about that, I think Steve would be a great resource on that, and you can also contact us. Margot, do we have time for a few more questions? I see a few more questions coming in.
Karen Berger asked a great question. I think maybe we have time for that. That might be our last one, because I want to make sure everyone has a few minutes between this and their 1 o'clock activity. So maybe this is the last one. Thank you.
Great. So was there a correlation between the existence of social needs and whether individuals found screening for these needs acceptable?
Yeah, great question. And not in our analyses. So regardless of social risk, whether you had multiple or none, people had similar levels of thinking that screening was appropriate and also being comfortable with that being integrated in their EHR. And that came through in the interviews as well, that people kind of who both said that they experienced and didn't experience that they would be comfortable, because I know it has been a concern in clinical practices where they are assuming low levels of social risk, that their patients would not feel comfortable or would find it strange to be asked about them. And studies are showing that that is not the case, that this can be done everywhere.
I want to thank all of our, sorry, were you going to say something before I wrapped up?
I was just going to say thank you and turn it back to you.
Well, that's my closing message too. I really wanted to give a warm thanks of appreciation to our terrific presentation, to our terrific presenters today. And also there were some great questions in the chat. I know that a lot of us have other questions too. I would encourage all of us to keep the dialogue going, because this is a really important topic. And all of our presenters today have expressed enthusiasm for being in touch with folks, answering questions, and just helping you find more ways to get involved. So thank you so much. Thanks to everybody for being here. Again, if you missed part of the session or you missed other Grand Rounds, they're on YouTube. You can find the link on the website. And I will give it back to one of our presenters, as I always do, to give your final words of goodbye to us.
Great. Well, Emilia or Matt, do you have any final words for folks?
Thank you so much for having us, and would love to talk more with any and all of you about this topic area. So thanks so much.
Yeah, there's a lot going on in this space. It's a very, very active space. And we would love to connect with anybody who is doing this kind of work, interested in learning more, etc.
Thank you so much.
Be in touch. Thanks again.
Yeah, bye.